map is dedicated to discussing the topic each week, this topic each bleh, with talk and conversation that hopefully will add more to the conversation about mental health and addiction. Joining me, as always, for the show is my friend and colleague, the one and only Kristen Perry Long. How are you, my friend?
I'm good. I'm good. How are you? It's summer and it's Friday.
Yeah, what beach are you at? Hampton.
Yeah, I'm at my home. I made Billy build me a beach.
Little Compton. What's up?
Yeah, what's up?
What's up? So
There's jellyfish in the water though. I can't go in.
don't get stung. People die that way, you know.
They said the tentacles are 100 feet long. How
At
does that
least.
happen?
At least.
That's crazy.
Um, and our other host for the show is the one and only Willie Drinkwater, who is on assignment. Now he says he will be back next week, allegedly, but we shall see.
I think he jumped ship.
Yeah, he'll be back. He sent me a text yesterday. I'm all excited. Okay. Um, Chris, before we get started, who are you?
So I am Chris Perry Long. I am an advocate and I work for an amazing company called Aware Recovery Care. It is a 52-week in-home addiction treatment program. Um, it it's everything that I've always talked about in that, when somebody walks out of treatment, they are handed the little business cards, connect with this therapist, connect with this MAT provider, yada, yada, yada. And, that's what we do. We work with the clients. We meet our clients where they're at. And today's guest is one of my coworkers, and it's a great company.
Well,
And
he's been on us before,
Dennis
actually.
has?
I believe so. Yeah, we've done so many of these things. I think he
I don't
has.
think Dennis has. I had Jason. There he
Oh
is.
no, I think Dennis was on before.
Dennis, were you on before? You're muted.
I was on before.
Oh, okay.
See?
Yeah.
Learn the guests. That's all I have to say. Learn the guests. Okay.
Who are you,
Um,
Andy?
and as for me, I've been in media. I'm Andy Bernstein. I've been in media one form or another for 20 plus years, and I believe media has the power to help this issue with programs such as this. Not we're the only program, but programs that have dedicated talk to mental health and addiction. I think is super important. And so away we go. As Chris mentioned, we have Dennis Leary, who is our special guest. He is a drug and alcohol counselor and quality care specialist with the aforementioned Aware Recovery Care. But I want to talk about a quick news headline before we get started with Dennis. And I read about this. This is unbelievable. I'm not surprised per se.
Oh,
But
this is the one about the high point, right?
yeah, so patient
Oh,
dumping.
I just picked this up because you sent it with so much time to read it. Um,
Wise
this
guy.
is nothing new. Like, this is nothing new. These kids, they get discharged, they get dropped off at the train station. Lots of luck. See you later. Bye. Like, this is not new news.
Well, no,
This
it's not, but at least
finally
it's
is
come to the
coming out
forefront,
about
though,
it.
and that's the cool part of it. At least somebody's like WBUR is talking about it. And so, for those of you who don't know, patient dumping is a statutorily imposed liability that occurs when a hospital is capable of providing the necessary medical care and transfers a patient to another facility or just simply turns the patient away because of the patient's inability to pay for services. So on June 10th, as Chris says, there's nothing new, but the article was after a woman's death report raises alarm over patient dumping from a psychiatric hospital. And the article talks about Cassania King, who was admitted to her third psychiatric hospital in a year in 2018, and her family thought she was going to get the help she needed. She spent 19 days at the now closed High Point Hospital in Middleborough, Mass, and was disoriented and severely ill. And she was discharged from the hospital, taken to Boston, where it appears she went where she was expected to go to a homeless shelter and she never checked in. And then 30 hours later, she was dead. And her family filed a suit over it. And they just came out with the report. And they said the Department of or Disability Law Center said that King's death raises questions about so-called patient dumping, where patients are suddenly discharged from treatment um, without. I don't.
That's
King.
just it.
That's what it says. Without. She had hallucinations and she was engaging in self dialogue. But I do that myself in self dialogue, so I don't really know. But
But it
she
goes back
wasn't
to the
provided.
mental health, right? It goes back to the mental health, and I'd love to talk about the country, but I don't live everywhere else. I live here in Massachusetts, and the way that we deal with mental health in Massachusetts is unacceptable. It's absolutely unacceptable. You have somebody that has mass health insurance, an HMO insurance. It's all about the insurance. It's all the insurance decides whether you can stay or you can go. And they're not treated or if you have
Well,
money.
right. They said that patient dumping occurs when a hospital denies emergency medical care or inappropriately discharges a current patient, learning that the individual upon learning the individual is unable to pay for treatment or for another reason. And then to round out the article, the full article is available online. But the Department of Mental Health is deeply saddened by Mace King's death, and immediately investigated the actions. Okay, so they're covering themselves,
Their tail.
and they said that they oppose the practice of patient dumping. But the article, which was interesting, said it shouldn't go unnoticed that this was a 44-year-old black woman when we're having a national conversation about race, equity, and health disparities. They said the report points out that some people's lives are dismissed, especially people with disabilities and particularly people of color with disabilities. So you've heard about it before. Our guest Dennis Leary from Aware, have you heard about this?
So I did not know. I don't know what is patient dumping, but like I know the process. And Chris, I just wanted to say that I believe and support your statement of the way mental health is treated in the United States. It's the probably one of the few parts of the medical system where an individual is reduced to a symptom of their disorder versus being an actual human being. You know, the behavioral health, right? It has the word health in it. Mental health, it has the word health in it. It is part of that healthcare treatment, right? However, you would be shocked, or maybe you wouldn't, but at the very least be appalled at hearing how patients that suffer or live with severe and persistent mental illness are even referred to in terms of language by providers. We
I
would
saw.
never, I just want to get this one part out. We would never refer to somebody as a cancer. We'd never refer to somebody as an AIDS. We'd never refer to somebody as a hepatitis. However, it is commonplace to hear someone referred to as nuts. It is a commonplace for you to hear somebody referred to as a schizophrenic versus a person living with schizophrenia. And these types of uncentered patient language goes on, more than we would, not only that we would like to know, but also the treatment of these individuals. Whereas, like Chris had mentioned, they don't treat, they stabilize. And sometimes they do a poor job of that as well. And
And
then,
they'll say that. That's the crazy part. Oh, we give you 2 weeks and we stabilize you. Please tell me what medicine in a pill form 2 weeks is going to stabilize a major mental health problem that isn't even diagnosed. I mean, it's
It,
it's a
it,
battle that we are losing.
so, Dennis, it's funny you say that. I worked for 2 days, two days, mind you.
I told him not to.
You know what? Let me tell you something, right? I had to explore it because I'm not going to lie, the money was good,
Yep.
right? It was good money. I wanted to see. And more importantly, the position was really interesting because it was something I created for myself. And I went to work for a treatment facility, not a facility, a, a care, well, what was it? A
It's a
chain of
treatment
surgery.
center.
And I don't want to mention the name, but I literally walked out in 2 days. I was out because, and I'm proud that I walked out because of the way they were talking about their patients.
Mm.
It was horrible. It was horrible. Like, these people are pains. They're not going to have money. It's going to be a pain. You got to talk to them about how you're going to get money for them, for their fam. Like you can't. You know, if they
It
don't
was
have
just bad. It was
insurance.
just bad.
It was bad the way they handled it. I was really disgusted, and I got up and walked out during the training. I'm like, this is not for me. I'm not even going down this road. But more importantly, I didn't like the way they treated their employees that they had, the way that, these were people in recovery. Most of them were in recovery, and they really were not nice to the people either. So I agree with you. Aware, we hear so many good things about Aware through Chris, and which is means a lot because she wouldn't be excited about something if she didn't believe in it. So, having said that, Dennis, thank you for coming on the show.
You're more than
We
welcome.
want
Happy
to,
to be here.
specifically, we're going to talk about the barriers that are affecting the LGBTQ community that they face for treatment. So, I'm going to let Dennis, if you would, give us a quick little background about yourself, and then I'm going to turn it over to Chris, who will take it from there.
Right. So my name is Dennis Leary. No relation to the actor, nor do I have his money. And I work for Aware Recovery Care, like Chris had mentioned. I've been with the company for 5 years. I started out in direct care. I then moved to clinical supervisor, moved over to healthcare quality and process improvement manager, and now I am on the community outreach team.
Okay.
I'm an addictions counselor by training and schooling.
And as your positions have changed, let me ask you, because that's our commonality, we've done outreach. What do you see when you go into doctors' offices, when you go into other types of providers? Is the reaction, oh, it's just another treatment center? Like, do you get that? Or do you like, oh, I've heard about Aware, it's great, blah, blah, blah? Or do you get a little mix of both?
A mix of both, right? So what I've noticed is, and this ties in right with the subject of the podcast. The first thing that's asked without fail at every single meeting is, who pays for this? How is it paid for? And how are the patients getting in? And because unfortunately we live in a society where the need for treatment comes secondary to the funding source, because insurance companies determine who gets into where, and that leaves a big chunk of the population that is marginalized and under or uninsured without access to resources that they desperately need.
Right. And so, I mean, we could talk about all we could talk about every type of person. We could talk in light of Pride Month. I really, really want to talk about the barriers that the LGBTQ community faces, because I understand, having worked for multiple treatment centers, the transgender, like when they go into detox, they're absolutely, well, how do you identify? Well, you identify, but you have parts. So where do we put you? Like how can be, it's just mind boggling. Let's talk about the barriers, Dennis.
Yeah, right. So there's a host of them, right? So one, there's institutional trauma, and that's just factual. Anybody that has to go to awaited treatment is going to suffer from some form of institutional trauma, because they're being removed from their home environment, from their comfortable surroundings, from their loved ones, and from their pets. When you take a population such as the LGBTQ plus population, it's more so because you have people that are well-meaning. I mean, honestly speaking, nobody gets involved in either the medical or the counseling / therapy profession to harm people. But when we think about intention, the road to hell is paved with good ones, right? So intention means little, outcome means everything. And so you have people who are uninformed who will take an individual who identifies as a woman and is, identifies themselves as being transgender. And, the person will look at their license and they could have just asked, how do you identify? And the person will say, transgender or as female. And they'll say, okay, but your license says Brian, so that's how you'll be referred to here. And or your insurance card says Larry, so that's how we're going to refer to you. And then they will then take this individual and they will put them on a male unit floor, which is now the person is subject to a population that may, a patient population that, may or may not be very well versed in that and get teased or get, be forced to take showers, at the allotted shower time when all the other males are taking showers, because most places have, communal bathrooms. And, and
That's terrible.
It's absolutely, it's a travesty. It shouldn't be.
Especially when you're going into a treatment center and this is voluntarily based, right? So you're going in, you're paying for it, and then they're saying you're going into it in a way that that person who's going in is already dealing with a lot of stuff on the outside, now goes into treatment and then and then has to deal with that on top of trying to get well or get better. You're immediately starting off in the hole.
Yeah. And so the answer to that is, a lot of times individuals won't go to treatment whatsoever, or even seek healthcare for that matter, because of the way they've been treated, or even just as bad, the indifference with which they are treated.
And that is a simple remedy by respecting who that person is and where they are.
And that's one of the great things actually about Aware, right? And that's why I love working for this company, because we are so patient-centered right from the start. One, if we can make the home environment the treatment center, which we're very successful at, the individual does not have to leave their home. They do not have to leave their pets or their loved ones. And they're able to recover in an environment with a team that is age, gender, and story matched to the individual, so that they are getting help with someone who knows their individualized struggles.
Apples to apples.
Right. So let's talk about that a little bit. Like, that's one of the big things that Aware really prides themselves on, is that they put you with somebody that you can relate to. You're not getting in there. You're not getting a 55-year-old person that suffers from alcohol use disorder with a 26-year-old substance use disorder, heroin, fentanyl. There's no relation. We are doing our best to match you with like-minded, with experience, and being on this side as the family wellness person, watching that bond happen with somebody. Those barriers right there are just, there's no barrier, because you're instantly relation, my alcoholism and my alcoholism, and you have that common conversation from the beginning.
Yeah. Go ahead, Dennis.
The problem with traditional treatment, right? I mean, one, it's a dinosaur. And, however, it's all that we've had. You take somebody out of their sociocultural environment, you put them away for a pre-designated period of time, and then you send them back to the same sick home environment with a pink slip of paper for a referral that says, call this number, attend these meetings, and, good luck to you. It's kind of like patient dumping in another sense. You're dumping them back into the same situation that got them needing treatment to begin with. And so what we do is we take a whole person approach to addiction treatment. Addiction is a multifaceted disease, and it has many different layers. So it needs a multi-pronged approach, right? So you need people from many different disciplines. You need people that have, very different skill sets, and you need to attack it on many different levels, because a lot of times people like to focus on the actual drug use, right? And the drug use is simply the period at the end of a long sentence. The substance use is a manifestation of everything else that's going on. Their social determinants of health, their sociocultural environment, their psychological state of being, their mental health, their behavioral, their physical health, right? If you're not feeling good, how are you expected to participate in your own treatment? So what AWARE believes is we're not just treating addiction, we're removing barriers to recovery, because that's what it's all about.
Sounds to me like what's different about your model compared to some of these other hospitals or to centers is that because you treat people at home, you don't have the problems of running out of beds or getting people in and out the door because of insurance or things like that. You're actually, your model allows you the ability to really treat everybody based off of the fact that you're going to the home. So you don't have that, rather than the overhead, just from a business perspective, you don't have the overhead of food, and you don't have the overhead of, you're like can really focus in on treatment rather than all the other external factors.
Yeah, our program actually, in terms of cost, a year in our program costs less than a 28-day stay in, I'm not going to say any names, but a traditional, residential unit for what you would normally pay. And our program costs less than that for a whole year. And the overhead has has a great part of that, because we're treating it. And not only that, but it gives us a whole different lens. We're able to go in there and assess the safety of the home. Well, the family wellness department is able to work with the family on helping guide, assist, coach, and support them on how to help your loved one on what that looks like through a full year of their first full year of recovery, as well as promoting self-care awareness, and the family is going through their own version of recovery too, because we know addiction, like I just said, it's multifaceted. It holds the family hostage as well. And so mom ends up becoming a nurse, dad ends up becoming a parole officer, and brothers and sisters end up becoming accomplices. So the family wellness has their own team that works just with the family on them recovering and getting them reassimilated into the correct roles. So mom can be focused on being a wife and a mother, and she doesn't have to be a nurse. That's why we have nurses on staff. Let our nurses do the nursing job, right? The sister doesn't have to be a social worker, because guess what? We have social workers on staff. There's no, so we want the family unit to be a family unit, and we want to focus on helping everybody be well.
Chris, what say you on that?
I have to say, I've been with the company since August, and watching how this program works from the family unit, I get goosebumps. It's everything that I've always known that they need. Like when you walk out of it, we don't compete with treatment centers, right? Somebody comes out of a treatment center, that's great. That means that they have 30, 40, 60 days of sobriety under their belt. They're clear-minded. Somebody walks out of detox. We know what happens when somebody walks out of detox. They're fragile. They're still going through withdrawals. We're there. We meet them where they're at, regardless. And the biggest thing is that we're not punitive. So what that means is that if somebody—
That's a big word for you, Chris. No, I'm kidding.
You need your dictionary there, Andrew?
Yeah.
What that means is that if somebody has a reoccurrence, they have a reoccurrence. It is what it is. We walk them through that process. We help them identify, and we walk the families through that, which previously was an enormous crisis when somebody had a reoccurrence. But I want to go back to the topic, Dennis.
Yes, please.
I really want to go back to the topic, and I want to talk about the LGBTQ plus community. And what is the plus? Is that transgender?
It's no. So LGBT stands for, it's really LGBTQIA currently. And what that stands for is lesbian, gay, bisexual, transgender, questioning, intersex, and asexual. So
What is intersex?
It's a more patient-centered way of referring to someone that's born with both genitalia sets.
Oh,
And so that's all under the same umbrella. However, it's most commonly referred to as LGBTQ plus because as time goes on and individuals and society becomes more centered towards the individual, I am presuming that the acronyms are going to even grow more. So, right, at first it was just LGB, right? Then LGBT, and then it's LGBTQ, and then it's LGBTQIA. So, but most
alphabet pretty soon.
Yeah. So it's most commonly referred to as LGBTQ plus.
So let me ask you, when you have somebody that identifies as transgender and they come into the AWARE program, we know that most of the time, like when somebody is struggling with their identity, right? Alcohol or substance are the symptom, not the issue at hand. What happens when somebody goes into? I understand like what you said before, but what happens? What's the difference between when somebody goes into a treatment center versus somebody's at home? I mean, I know the answer to this, but I think we need to talk about it because I think it's really important when somebody comes into like AWARE and they're able to stay at home.
Right. So it all begins with the assessment process, right? It all begins with, that's the first interaction the individual has with a potential client. And so right from the beginning, we're inquiring about sexual identity. We're inquiring about, gender or, sexual orientation, gender identity. And that's how that person is referred to from coming in. Because, what I can tell you is this, from experience, from being, an out loud and proud gay male myself, is that I'm never offended and nobody ever will be offended if you ask them, how would you like to be referred to? I don't take presumptions, right? We know gender identity has nothing to do with gender expression. Gender expression, I express myself as a male, right? But for all intents and purposes, I still could identify as transgender and I could be a woman internally. It has nothing to do with outward appearance or genitalia. So we ask, and an individual will appreciate you taking the time to ask what their pronouns are, right? And that's how I start off almost any 99.9% of conversations that I'm having with an individual. And I break the ice really quickly. My name is Dennis and my pronouns are he, him, his. How about yours? And based on that person's answer, how they want to be referred to. And there's the most common pronouns are he, him, her, hers, and they, them. And they, them is for people that don't identify with either gender. Yep. And so right from the beginning, you're getting a sense of who this client is, how they identify, and how they want to be referred to as. And that makes a big difference because it sets the stage for your relationship with the client moving forward. And if you want to refer to, I'm being, I'm taking a stretch here, but like if you tell me your pronouns are chair, like that's how I'm going to refer to you, because that's about you and that's what you want to be referred to as. And I believe that anybody and everybody has the right to express themselves, be referred to as, and identify how they feel and who they are, with who they are.
So let me ask a question. So when you talk about this, and from an insurance perspective, because I don't know, you guys take Mass Health. You don't take Mass Health. Is it self-pay or?
We can do self-pay. We take every facility, every location takes different insurances based on the state.
So here's my question. does the name or the gender affect the insurance coverage?
No,
Okay.
because you can look at it from a few different lenses, right? Um, an individual, if they happen to be going through their transition and they haven't reached the point to where they've changed their license and had, done all of that paperwork, you're going to have you're going to have two names basically, right? You're going to have the birth name, the name that was assigned at birth, and that's on all their legal documentation. However, in terms of treatment, if the person identifies as a female, all their notes will be written with the person's pronouns as she, hers, or her. It might be they, them, for how the person chooses to identify. So, from a patient-centered stance, we're going to refer to you and treat you as what you identify as versus what the sex you were assigned at birth. For insurance purposes, all documentation being submitted to the insurance company would have to be, under that prior name. But the patient knows that because they're furnishing you with that information.
Okay. Chris, what else? What other?
So back to like the barriers, right? So you go into treatment, you actually get into a treatment center it has the ability to recognize how you identify. What happens when you get done with treatment? Like, what are those barriers going back into society, back into life? I know, like we've talked about, it where we're not removing them from society. We're not removing people from society. We are helping them deal with life on life's terms. But what happens, with the difference? Like, you make this person whole again, and then what happens?
Yeah. Let's talk about that statement for a second, right? So if you've gone, there's a popular saying, if you've gone 30 miles into the woods, you have to come 30 miles out, right? There's no shortcut for that. And so when you have a person, that is, been using for, let's just say 5 years, right? And they've had an active addiction and substance use disorder for the past 5 years. It's impossible for them to be well and whole in 28 days and removed from their socio-cultural environment. But they can be stabilized, right? So let's just say that an individual is in a 28-day program and then is discharged, and they're going back into their same socio-cultural environment. Here's where the issue comes in. If nothing's changed, then nothing's changed. They're going to be subjected to all the same social pressures. And we're talking about LGBTQ plus individuals right now. They're going to be introduced to the same social pressures. They're going to be exposed to the same negative peer group associations. Their safe places are still going to be the same safe places that they've had in the past. And when you look at historically, pretty much the only safe space for the LGBTQ plus community to congregate has been bars and clubs, right? And what do you have there? You have alcohol, you have cigarettes, you have a host of other illicit substances. And so that's the main difference, right? You're putting them right back into the same situation what got them into treatment before. Now, as opposed to working with Aware, who does in-home addiction treatment, we're a year-long continuum, and we're in the socio-cultural environment with the client. So we're able to help coach, guide, and assist that client on how to react to negative peer group associations. We're able to have a comprehensive relapse prevention plan with the client based off of real life circumstances in their community. We're also able to expose, we're not bound to traditional brick and mortar treatment, which is fee for service, and the client is bound to going not only to a place that's associated, that has the stigma associated to it of mental health and or addiction, but no change happens clinically speaking in the office with the therapist or the doctor or whomever. It happens when they're back home and they need to employ those interventions. That's where we come in. So we are able to teach the client about what healthy relationships look like in real time. We're able to help the client not only identify activities that are recovery, supportive of recovery. We're able to actually go with the client outside the home to said events so we can help them find meetups. We can help them find, a host of other self-help groups that, depending on the individual, may or may not be LGBTQ plus focused, because because I'm a gay male, that doesn't necessarily mean that I want to pigeon myself into an LGBTQ plus box. I may not want to go to gay AA meetings. I may not want to go to gay smart recovery or whatever have you, but I may want to do that as well. So we take the time and the opportunity to expose these individuals to, a whole host of interventions that they can employ in real time in their environment, right there in their sociocultural community.
Chris?
Which I've seen make a huge difference.
Do you feel that over time, people that identify however they identify, are more open to receiving help? Because like what I've noticed is that the LGBTQ community doesn't want to get help because it's just another label. So now you're a gay male that's a heroin addict, and like that's how I mean, they're identified. People that have addictions are identified, and I do not like this word, as junkies, right? But now you're a male junkie. Is that an even bigger, kick in the teeth?
Well, I mean, right. So this is a kind of a dually part, a multi-answer question. So if you have somebody that identifies as gay, we'll use gay for a moment, right? You're already part of a marginalized community. If that is a person of color, they're dually marginalized. If that person is gay, a person of color and a heroin addict, you've got a trifecta here, right? What I will say is this, statistically speaking, the LGBTQ plus community seeks treatment for substance use disorder and mental health at the rate of 2 times their heterosexual counterparts. So and so what you'll see is now you're going to have your outliers, right? You're going to have your outliers, and you're going to have individuals that refuse to seek treatment because of, bias on the part of the treatment world. However, these individuals want help. These individuals want to seek treatment, and they want to be restored to their former levels of functioning. The problem with that is the main barrier is access, right? The other main barrier is, despite clear-cut evidence being shown that specialized treatment tracks work and have greater outcomes. There was a study done by I want to say it was the National Institute on Drug Abuse. I could be off on the originating source, so don't quote me. However, the statistics that came from it, I'm very well versed in. And that is, out of 911 treatment programs that were surveyed across the United States and Puerto Rico, 70% reported having a specialized track for the LGBTQ plus community. However, upon further investigation, the number of treatment centers that actually had something that differed from their traditional track was 7%. So 7%.
Yep.
Right. 70% reported they had them, but in truth, the majority of those were no different from their standard treatment protocols. Right. However, there was a study done out of New York City, and I think it was a small scale study. 189 men that identified as gay or bisexual went through treatment with a specialized track, and they had 60% greater outcomes than the people that went through no individual. Because when you look at it, right, we are individuals, right? We being gay, lesbian, bisexual, or transgender comes with a whole host of different trauma, comes with a whole host of different life circumstances, comes with a whole host of culture, right? Because for instance, in the gay male culture, crystal meth is a huge problem, right? Crystal meth is intrinsically tied with sexual behaviors and loosened inhibitions. And so a lot of times gay men can't associate sex without associating crystal meth for the individuals that have a substance use disorder, right?
And hold on there. And what do treatment centers see crystal meth as?
I'm not
a non-addictive, drug.
Well, yeah. So like it's a drug that doesn't require detox. They focus on the usage, right? But they don't take into account the socio-cultural aspect of it that goes behind that, right? So like the same thing, like you could have a gay male who may report that they had a crystal meth binge and had 40 sexual partners over the weekend, and everything from the person receiving that information's facial expression to what their reaction is going to form a basis of how that person responds to treatment.
Let me.
I would add humor. I would say, "Well, congratulations, you had a busy weekend. Let's talk about the use."
So let me throw my conspiracy theory part of me out. Would it be, just hearing that crystal meth is not regarded as an addictive substance, right, to what we're talking about? Does it have to do with the fact that where it comes from? Like, in other words, where's it come from? Like Robitussin and like pharmaceutical.
Yeah, it comes from antihistamine. There's a whole host of things in there.
Right.
I forget even how to pronounce it. Methadone. It comes from cold medicines, cough medicines. It has I've heard that there's Drano in it. I've heard there's all kinds of things in it. I don't know the chemical makeup. I just know that it's poison.
Right. So it doesn't have a corporate feel to it, like, oh, well, if we do this, then it shows a bad look on, it puts a pharmacy and a pharmaceutical company and somebody, like, is there any kind of corporate reasons why they don't treat it, in thinking about it, because it's not a natural substance, it's
education, Andy. It's lack of education. It's lack of acknowledgement that people could have an addiction to crystal meth, and we don't as a society, because it's typically connected to I believe gay men, and help me out here, Dennis, but it's because of what it's connected to and the behaviors that it's not. It's like people just don't acknowledge it. Like you can't go into detox if you have to say, I have an alcohol problem and I use crystal meth. It can't just be crystal meth. Insurance won't pay for it.
Yeah, they also won't pay for cocaine. They won't pay for marijuana. Like the only time that they'll say that an individual requires detoxification is if it's medically necessary to that the withdrawals are dangerous in the terms of their biomedical condition. So alcohol withdrawal can send you into a seizure. Benzodiazepine withdrawal, is physically dangerous. Alcohol, if I'm not mistaken, is the most dangerous. Mm-hmm. And so those situations, heroin, opiates require medical detox as well. So for those categories, individuals are not required, but they'll be admitted into detox. But for any other addiction, whether it's to cocaine, crystal meth, marijuana, or any host of any other K2 or anything else, they would not be admitted into detox because they would say it's not medically necessary.
That's unbelievable to me.
If you go to websites of treatment centers, it'll list off all of those things that they'll treat you for. But getting it, you have to have one of those other substances connected to you. So now what you're doing is you're like, recovery is supposed to be about honesty, right? So now you are making that individual be, they're finally able to admit that, okay, you know what? I have a crystal meth problem. I identify as being gay. I want help. Okay, well, what else are you addicted to? That's it.
And then now you have to when you in any kind of intake, or when somebody's trying to get to you, like you almost have to kind of tweak your the way your substance abuse to make sure that insurance doesn't cut you off because you're not being truthful in your. In other words, if you're like, well, I have a bigger meth problem, not me, but if I have a bigger meth problem than an alcohol problem, does that send off a red flag to um, somebody in treatment to say, oh, that person has more of a meth problem? In other words, does it create, when you're filing a report or you're trying to take notes on the person, does that put that person in an uncomfortable position because they have to
Hi.
um, report it more on the alcohol side than the meth side. In other words,
And to get into, I understand what you're saying, Andy. To get into detox, an individual has to be given assessments and then and vitals being taken. So for individuals with opiates and alcohol, they're going to be issued either a COWS or a CEWA assessment, right, which measures things like anxiety and things of that nature. And so what's going to happen is then nurses are going to take blood pressure. They're going to take your pulse, and they have a set standard of guidelines that they need to follow. And so a person's blood pressure needs to be at X for them to be in a state of detox. They need, the person's, whatever other vitals that they're taking, respiratory or whatever, need to be at certain metrics. When they fall within those metrics, then the person's going to be able to get into detox. But somebody that would come in and just say, like, I have an alcohol use disorder as well as a methamphetamine use disorder, they're going to measure what that person's vitals are. And if they know medically what detox looks like, right? And so they're going to base their decision off that triage. So,
okay.
So like I could go in there and say, like, hey, I'm addicted to alcohol. They're going to say, when's the last time you had a drink? And I say, I don't know, last night. Then my heart rate would be somewhere, my respiratory would be somewhere, my COWS score, my CEWA score would be somewhere. I have to meet all those metrics to be able to be admitted medically into detox.
Got it. So this is fascinating. I mean, how do you? Okay, so now we know the barriers. So what can people do? How do they if they need to get into treatment? Like how do you? Is it about becoming an advocate for yourself to say, you know what, that's unacceptable to me in the way that you're handling my situation, or that's unacceptable to, like almost like I'm learning that, you really have to be an advocate for yourself to kind of navigate all this red tape in order to do that. It sounds like Aware does not have the red tape, but for somebody who may need to get treatment, like, what do you do? How do you navigate this?
Right. So there's a few different ways that an individual can advocate. So for individuals that have HIV, there's places like Ryan White organizations which have funds available to help pay for substance abuse and mental health treatment. If you're an individual that identifies as under the LGBTQ plus umbrella, there are community agencies out there that can help. However, if you're a commercially insured individual and your insurance company doesn't want to pay for something, you really do you have to appeal. You have to grieve the situation. You have to be a voice for yourself. Now, with that being said, um, another way, to address this, is as a community, we need to say that this isn't acceptable, right? We need to bring awareness to legislators, to legislators. We need to speak out to, the governors of our states, to anybody who will listen, who's in a position of power or has access to people that are in positions of decision-making authority, to change these things. Because what it all comes down to, and this goes with anything, this goes with HIV, this goes with cancer, this goes with gay, this goes with, anything that people don't know about, it all comes back to lack of education and stigma, and which equals fear, right? And so it's about educating society at large. It's about platforms like this where you talk about these things where people are uncomfortable talking about it, because nothing gets changed by being kept in the dark, right? You need to shine a light on it. You need to expose it. You need to take it out of the proverbial closet. You need to get people aware and talking about it, and get these, you need to help people get comfortable with being uncomfortable. Because if you're uncomfortable talking about something, that's got something to do with you, not the issue at hand. Because we should, as a society, we should be able to be comfortable talking about anything that's going on within our community.
Exactly. And if you're not comfortable talking about it, it's because you're afraid of the reaction, and and that holds you. I mean, this whole pandemic, right? We as a addiction as a whole was just starting to come out of the cocoon of the stigma. And when, COVID happened, we lost that momentum. What did they say? It was something like reported overdoses.
89,000 overdoses from, I think it was from June to June.
Up right? 11,000, right? Or something like that?
It was the highest. I don't know the number of how high, what it was higher than the past one, but I know it was a record year for overdoses and overdose deaths.
Right. Reported. Let's be honest here. Reported, because yes. Our hospitals don't always.
I know a guy who died of a heart attack. He was 54. And the heart attack was largely because he was alone and he wasn't taking good care of himself, and he was a substance use, and he abused substances. But he died of a heart attack. So is that considered an overdose?
It is, but they won't list it as that. They'll report it as a heart attack, so it doesn't get linked to the overdoses.
And I've told the people, a friend of mine who was really close with him, said, listen, you know what? He may have died of a heart attack, but we know there was more to the story.
Yeah.
But yet the family really wants to roll with heart attack.
Exactly. And you go into the hospital, and you're not identified as a addict, and you're having problems breathing because you're in the process of having an overdose, hospitals report it as a respiratory distress, and then that's how they died.
It's like somebody going in. It's like somebody going in because of a heroin or an opiate use, opiate-based overdose, right? They're going to, in most cases, report that as cardiac arrest, or whatever the medical term is for your heart stopping. That's what they're going to report it as. While yes, that's the physical cause of death, but it was induced by using heroin or fentanyl or whatever the substances.
Again, the stigma, right? Stigma. Hospitals, people don't want to hear about it. They don't care. I mean, I have to put. I think Massachusetts lost something like 2014. I don't know. I have to look through my notes. This year alone, I think that's the highest. And so that's when I do my stakes are high, right? That's another. We were over 10,000. So that means there's going to be 12,000 flags that are going to be placed this year in the state of Massachusetts from 2015 to 2020, which is insane. It's insane.
So if people want to get in touch with either of you, how do they do it?
Right. So I'm going to put my name and my phone number in the chat, as well as I'm going to mention it right now.
Okay.
Anyone can call me at 203-631-2556. and my email is dleary@awarerecoverycare.com.
Excellent.
And if anybody wants to get in touch with them and they didn't get that number, I will get you in touch with them.
And then Chris is an all-purpose person. She'll help you with anything. Literally, she can help you with anything. She's Johnny on the spot.
Yeah, when I meet with providers, part of my role as community outreach manager is not just bringing awareness to the program, but being there as a support for these community providers, because we consider them partners. And so I always tell them, so like if you have a client that's not a shared patient, but they need socks, like I know who's giving out socks. I'm like the Home Depot of community-based resources over here because I work with so many agencies, right? So I know who's got a food pantry, who's got the good food. I know, like, we'll stay away from that when they just got canned goods. And so, like,
Canned peaches, spam.
Yeah, they've got potted meat product. We want to stay away from those. Let's go over here.
Away from the potted meat.
They give gift cards over here, so let's go over
Sardines.
What Aware location are you located at?
I'm located at Connecticut, but somebody from so we're in 6 states right now. We are in Maine, we're in New Hampshire, we're in Massachusetts, we're in Connecticut, we're in Florida and Indiana. So if somebody wants to give me a call, like I can take care of any of their needs for any of the states. So again, jack of all trades, master of none here.
Hear ya. And Chris can help. Chris is at the beach today. I heard a bird chirping. I don't know whose bird that was, but I heard birds chirping. What's that?
My windows are open.
Oh, I thought it was for effect, like it was like a sound.
It was a loop. It was a loop, yeah.
We have a client engagement specialist, and he has birds. So we'll be on like a team meeting, and his bird will be so flipping loud, and he's trying to talk. You know who I'm talking about, Dennis? Rich.
Oh.
Yeah, Rich has birds.
Don't mention names. No names. Give your phone number. Give your info.
Chris Long, 508-212-7206.
Can I have it a little more enthusiasm?
Everybody knows my number.
Well, okay. All right. That's our show. On that note, that's our show for the week. Thank you to Michael Weber at Back in Mission Control in Foxboro at Foxboro Cable Access Television. He keeps the train moving. Thank you, Dennis Leary, for coming on from Aware Recovery. Much appreciated. Thank you. Great information. Kristen Perry Long, as always.
Thank you, Andrew.
You're welcome.
Thank you,
You're
everyone.
welcome.
It was nice to see you. I miss you.
I miss you. Oh, I thought you
were talking to me.
All right.
I'm not talking to you. Andrew lives in the next town over.
He does. All right, let's cue up the music. That's our show for the week. Visit us on facebook.com/themap2020 and like us, review us, rate us.
Share us. If you have a topic that you want to talk about that nobody else wants to talk about, let us know.
You've just left that open to something really insane.
All right.
Not insane, something very unique. All right, let's cue the music up.
Have a good weekend, guys.
Bye, everybody.